Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA call, 2021 to 2022 recommendations for influenza prevention and treatment in children, an update for pediatric practitioners. All participants joining us today are in listen-only mode. Next slide, please. Free continuing education is offered for this webinar. Instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, CDC, our planners, our presenters, and their spouses, partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, except Dr. Flor Munoz would like to disclose that she receives a royalty for authoring the Seasonal Influenza in Children chapter in Up to Date, and is a member of the Data Safety Monitoring Board, Pfizer Moderna, and a member of the American Academy of Pediatrics Committee on Infectious Diseases. Planners have reviewed content to ensure there is no bias. This presentation will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. At the conclusion of today's session, the participants will be able to accomplish the following: review data from the 2020 to 2021 US influenza season to inform preparations for the 2021 to 2022 US influenza season, highlight key recommendations in the AAP influenza policy statement, recommendations for prevention and control of influenza in children 2021 to 2022, and in the CDC Advisory Committee on Immunization Practices document, Prevention and Control of Seasonal Influenza with Vaccines, recommendations of the Advisory Committee on Immunization Practices, United States 2021 to 2022 influenza season. Discuss the importance of vaccinating, testing, and treating influenza during the COVID-19 pandemic, and review recommendations about using influenza antivirals in children. After the presentation, there will be a Q&A session. You may submit questions at any time during today's presentations. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note we receive many more questions than we can often answer during our webinars. If you're a patient, please refer your questions to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to welcome our presenters for today's COCA call. We are pleased to have with us Dr. David Shea, who is a medical officer in the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. We also have Dr. Flor Munoz, who's an associate professor of pediatrics, infectious diseases, and molecular virology and microbiology at Baylor College of Medicine. It is my pleasure now to turn it over to Dr. Shea. Dr. Shea, please proceed.
Thank you. My name is David Shea, and I'm from CDC's Influenza Division. Next slide, please. So we're going to start out with a review of last season, and really for flu. I mean, was there a last season? We all know that not much happened. Next slide, please. So to confirm, influenza activity was unusually low in the US and actually globally during 2021. For example, during September 2020 through May 2021, only 0.2% of specimens submitted for respiratory testing were positive for influenza. And to put that into contrast, for the 3 seasons before the COVID pandemic, the proportions of specimens testing positive for flu peaked between 26 and 30%. So this lack of activity directly led to dramatically fewer illnesses, hospitalizations, and deaths related to flu. For example, the cumulative rate of lab-confirmed influenza hospitalization was the lowest recorded since data collection began in this large system in 2005. More to the point for pediatrics, CDC received only 1 report of a pediatric flu death in 2020 to 2021. And that had previously ranged from a low of 37 during the 11-12 season to a high of 199 in the preceding season, 2019 to 2020. Next slide, please. So why was flu so low last year? Obviously, the COVID-19 mitigation measures played a role. Perhaps in sort of rough order of importance, we have physical distancing, particularly during the winter season, wearing of face masks, improved hand hygiene in many situations, including sort of outside of the usual healthcare situations, school closures, and perhaps improved indoor ventilation. I think it's helpful to think about how less transmissible flu is compared to COVID-19. There's a concept called R0, which is the number of new cases that an infected person may cause in a naive population. And for flu, that range for R0 is thought to be 1.3 to 1.5, or each case leads to 1.3 to 1.5 new cases. For SARS, that range is thought to be for R0 on the order of 1.5 to 3, and with the Delta variant up to 5. And further context is provided that most infectious sort of typical viral disease of childhood is measles, which has an R0 of 12 to 18. So in other words, distances and physical distancing and other measures that reduce COVID-19 probably led to a dramatic decrease in flu circulation. It was also a year that a record number of flu vaccine doses were distributed. Next slide, please. So this is the season thus far this year, and as you can see, and this extends through last week as well, that there have been very few confirmed flu positives thus far in the United States, and flu season, we would say, has not yet begun. Next slide, please. And as I mentioned a few slides ago, there was only one pediatric flu death reported last year, and you can see that in week 47 of 2020. And the graphs for the 3 seasons before show the kind of the typical range of well over 100 deaths per year, making in typical seasons, flu is actually the vaccine preventable disease associated with the most deaths in children. But again, last year we only had one. Next slide, please. So these are preliminary estimates of illnesses, visits, hospitalizations, and deaths associated with influenza during 2019 to 2020. There's an estimate by age group for each outcome and a corresponding uncertainty interval around these estimates. Focusing on the pediatric age group, so adding the 0 to 4 and 5 to 17 age ranges together, there were about 11.5 million flu illnesses that season, 6.6 million visits, 42,000 hospitalizations, and perhaps up to 486 deaths. Note that that estimated total of 486 exceeds the number that were reported of 199, which reflects the known underreporting of flu outcomes, in particular the lack of confirmatory flu testing for all suspected influenza hospitalizations. Next slide, please. These slides show the proportion of flu outcomes for each of those categories by age group. And this is a pattern that's very consistent from year to year for flu and for pediatrics in the pediatric population. The bulk of more serious flu outcomes, hospitalizations, and deaths occur in older people, as is well established. But substantial proportions of medical visits for flu occur in children aged 0 to 4 and 5 to 19 years. And this pattern, again, holds typically for flu season. So illnesses sort of peak perhaps in younger persons, but medical visits and a substantial number of hospitalizations are due to, in particular, children 0 to 4 years of age. Next slide, please. Here are some links to additional sources of flu data as we head into this flu season this year. Beginning in October, there's typically more detailed reports of flu activity as it begins to pick up on the FluView website. And it's a good resource to check periodically for updates. It has a weekly report, in addition, a component called FluView Interactive that lets you pull down specific data, perhaps in an age group that you are interested in or in a region of the country. Next slide, please. We'll review CDC's antiviral treatment recommendations next. So as you know, antiviral treatment is recommended as early as possible for any patient with confirmed or suspected influenza who is hospitalized, has severe, complicated, or progressive illness, or is at high risk for influenza complications. Next slide, please. And we typically define those people at high risk for complications as children less than 2, adults age 65 and over, pregnant or postpartum women, children less than 18 receiving long-term aspirin therapy because of concern about Reye syndrome, persons with American Indian or Alaskan Native ethnicity, people with some underlying medical conditions, in particular pulmonary, cardiac, immunosuppression, neurologic, and neurodevelopmental conditions, and residents of nursing homes or other long-term care, chronic care facilities. Next slide, please. So antiviral treatment is recommended by CDC as early as possible for any patient with confirmed or suspected flu, again, who's hospitalized, has severe illness, or is at high risk. Antiviral treatment can be considered for any previously healthy symptomatic outpatient not at high risk based on clinical judgment if treatment can be initiated within 48 hours of illness onset. And that condition is because we know that these medications have their greatest benefit if given early during the course of illness. Next slide, please. So right now there are 4 antiviral medications recommended for use in the United States. You're probably more familiar with the 3 neuraminidase inhibitors, oseltamivir, zanamivir, peramivir. There is, however, a new agent, a cap-dependent endonuclease inhibitor called baloxavir that is also an oral medication. Next slide, please. This table summarizes the differences between these available antiviral medications. Oseltamivir and baloxavir are both oral preparations. Zanamivir is administered using a disc-haler device, and peramivir is IV only. Oseltamivir can be given to persons of any age, including infants, according to CDC, if they have a disease process that justifies it. Zanamivir is approved for children age 7 and up. And because it is inhaled and has been associated with bronchospasm in those with pre-existing asthma, it is not recommended for use in anyone with underlying airway disease. Peramivir is licensed for those 2 and up and is again IV only. And baloxavir, the new agent, has been approved by FDA for treatment of acute uncomplicated influenza within 2 days of illness in people 12 years and older. Next slide, please. So a little bit more about baloxavir. It is a relatively new drug, as I said. It acts through a new mechanism of action that directly blocks viral replication. It was FDA approved in October 2018 for acute influenza in patients aged 12 through 64 years. It is an oral medication given in a single dose, and that's perhaps the advantage of this particular preparation. Dosage is based on weight, with those weighing 40 to 80 kilos taking 1 40 milligram dose, and those greater than 80 kilograms taking 1 80 milligram dose. In clinical trials, baloxavir was associated with significantly shorter time to alleviation of symptoms than placebo, was also contributed to significantly more rapid declines in viral load and shorter duration of infectious virus detection than either oseltamivir or placebo. And again, similar to the existing antiviral drugs and neuraminidase inhibitors, clinical benefit was greatest when initiated early after illness onset. Finally, it is worth pointing out for this agent that the emergence of viral escape mutants with reduced susceptibility to the drug were observed in clinical trials and in some family clusters. So it will be important to continue surveillance for the emergence of possibly antiviral resistance in people who receive this medication. Next slide, please. Next, we'll turn to the most recent ACIP recommendations for use of influenza vaccinations, the 2021-22 recommendations, which were published in August. Again, just to go over some background information that I'm sure you're aware of, ACIP makes no preferential recommendation for use of a specific vaccine when more than one licensed, recommended, and age-appropriate vaccine is available. During this flu season, the following vaccines are available and expected to have good supply: inactivated influenza vaccines, recombinant influenza vaccine, and live attenuated influenza vaccine. Next slide, please. So again, as you know, routine annual flu vaccination is recommended for all persons aged 6 months and older who do not have a contraindication. Vaccination is recommended for all, however, if supply is limited, the recommendations are to vaccinate those at highest risk. And those would include persons aged 6 months and older who are increased risk of complications and severe illness, similar to what we talked about already, and contacts and caregivers of persons who are less than 5, greater than 50, or with medical conditions that put them at greater risk for severe complications of influenza, such as coexisting heart or cardiac or pulmonary disease. Next slide, please. And again, just to go over that list in a little bit more detail. So that'd be children aged 6 through 59 months and adults greater than 50, persons with chronic pulmonary diseases, including asthma, cardiovascular, renal, hepatic, neurologic, hematologic, or metabolic disorders, including diabetes, immunosuppressed persons, women who are or will be pregnant during the influenza season. Again, children and adolescents who receive aspirin or salicylic containing medications, residents of nursing homes or other long-term care facilities, those with American Indian or Alaska Native ethnicity, and persons who are extremely obese, here defined as a BMI of greater than or equal to 40. Next slide, please. So some specifics from this year's influenza statements. All seasonal flu vaccines available for use in the United States this season are quadrivalent in nature. For this year, the US influenza vaccines were updated to include new components for the H1N1 pandemic 09 and the H3N2 influenza A components. The age indication for the cell culture-based inactivated influenza vaccine, known as Flucelvax quadrivalent, was extended from its previous indication of those greater than or equal to 4 down to those ages greater than or equal to 2. And finally, and perhaps particularly of concern this season, administration of influenza vaccines with other vaccines is fine, and co-administration of influenza and other COVID-19 vaccines is encouraged. Next slide, please. So the guidance for use of vaccines in this season now states that vaccination should proceed soon after it becomes available, can be considered for pregnant women in their 3rd trimester, and that children who need 2 doses, again, those aged 6 months through 8 years who haven't received a previous flu vaccination or haven't received a total of 2 doses in the past, should receive their first dose as soon as possible after it's available, ideally to allow the second dose, which of course must be given at least 4 weeks later, to be received by the end of October of this month. Next slide, please. There's some new information about contraindications and precautions for the use of the cell-based and the recombinant influenza vaccines for those who have a history of severe allergic reactions to an influenza vaccine. And specifically, that information is that in those with a history of a severe allergic reaction to a previous dose of any egg-based influenza vaccine is a precaution to the use of either of these vaccines, the cell-based or the recombinant vaccine. Use of these 2 vaccines in such instances should occur in a medical setting under the supervision of a provider who can recognize and manage a severe allergic reaction, and that would include allergy specialists. History of a severe allergic reaction to any cell-based vaccine is a contraindication to future use of the cell-based vaccine, and history of a severe allergic reaction to any recombinant vaccine is a contraindication to the future use of recombinant flu vaccines. Next slide, please. And again, all the vaccines this year are quadrivalent. And again, the components for the H1N1 09 pandemic-like virus, and the H3N2 viruses were updated. And these list the specific antigens that are used for the vaccine this year. The use of the quadrivalent vaccine, of course, means that there is a Victoria B virus and a Yamagata B virus included in all preparations for this season. Next slide, please. And to go into a little bit more specifics about the labeling change for the cell-based vaccine. In March 2001, FDA approved the use of Flucelvax for use in children aged 2 through 4 years, and is again previously approved only in those aged 4 and older. Initial approval for those based 4 through 18 was based on immunogenicity data only, and FDA required a post-marketing efficacy study. The expanded approval was based on a randomized observer-blinded clinical study that was conducted among children aged 2 through 18 over 3 seasons. And in this trial, the vaccine demonstrated efficacy against laboratory-confirmed influenza of approximately 55% compared with a non-influenza control vaccine. Next slide, please. And finally, some more thoughts about co-administration of flu and COVID-19 vaccines. As you know, simultaneous administration of live and inactivated vaccines yields seroconversion and adverse reaction rates generally similar to those found when these vaccines are given separately, particularly in pediatric populations. So the recommendation for this year is that COVID-19 vaccines may be administered without regard to the timing of the other vaccines, and that would include simultaneous administration of COVID-19 vaccine and other vaccines on the same day. We don't know specifically if reactogenicity of COVID vaccines changes with co-administration, because this was not, such data are not yet available from clinical trials. However, monitoring of co-administration is going on at CDC through the usual vaccine safety surveillance platforms. When deciding whether to administer vaccines with a COVID-19 vaccine, consider whether the patient is behind or at risk of becoming behind in their recommended vaccine schedule, the risk of vaccine preventable disease, and the reactogenicity profile of any vaccines given in addition to COVID-19 vaccine. Of course, administer each vaccine in a different site and administer COVID-19 vaccines and vaccines that are more likely to cause local reactogenicity in different limbs, if at all possible. Next slide, please. And this just lists some resources that are available. The CDC flu homepage, again, the flu surveillance sites we talked about previously. As you know, there are specific web sites available for professionals as well as for the general public concerning flu. The 2021 flu, I didn't update this, is 2021. ACIP recommendations have been published and our antiviral homepage has been updated. And finally, CDC and AAP have created a website and an activity book together. Next slide, please. Thank you for your attention. And I'd like to turn the presentation over now to Dr. Flor Munoz. Dr. Munoz.
Dr. Munoz, you're still muted. Please check your mute button. For our attendees, please stand by. Dr. Munoz seems to be experiencing some technical difficulties. We'll try and have her reconnect and restart her portion as soon as we can. Please stand by. Please stand by. We are connecting Dr. Munoz in the next few moments.
Hello, can you hear me now?
Yes, Dr. Munoz, thank you so much. Sorry to our audience for any technical difficulties. Dr. Munoz, can I hear a little bit more from you to make sure we have a good audio?
Yes, thank you so much. I apologize as well. I hope you can hear me well now.
We can hear you loud and clear. Thank you so much. Please proceed.
Perfect. Thank you so much. And again, my apologies as well for everyone. I am very pleased to discuss with you today the recommendations from the American Academy of Pediatrics. And so in the next slide, please. I will be able to share with you the recommendations that the American Academy of Pediatrics has put together for this season, 2021-2022, and discuss some of the considerations regarding influenza and COVID-19 for this season, as Dr. Shea has as well. Next slide, please. So this is the current document. Just a quick update for everyone. We have in the past traditionally had a single document coming from the AAP on recommendations for prevention and control of influenza. This year, we have two documents that complement each other. One is a policy statement that has a summary of the recommendations, as you see here. And the other is a technical report for those of you who are interested in reviewing in more detail the guidance and also the resources and references available to support the guidance. This is what we would like you to see. And this publication is going to be available to you soon. Next slide, please. So I won't spend too much time discussing some of the updates. I did want to make some points in addition to what Dr. Shea has already mentioned. And just to remind everyone that we, of course, had a very abnormal influenza season last year with practically no influenza activity, but we are seeing already a little bit of influenza circulating even before the season begins. Of course, it is impossible to know what the season will look like, but just wanted to point out that it might be that this season we could see influenza in more numbers than what we had last year, simply because I think the conditions are in place. There's more opportunity for people to interact. There's more mobility, more international travel, and certainly potentially a vulnerable population that has not been vaccinated or has not been infected with influenza for at least a full season. So in the next slide, these are, of course, all CDC data, also showing you that when you look at the age groups of those that have had influenza-like illness recently, the younger children always tend to be well represented. The 0 to 4-year-olds, as we know, tend to have influenza-like illness or respiratory illnesses often, and that is true also for school-aged children as they have more opportunities to interact. The next slide is to show you, as Dr. Shea mentioned, that fortunately we haven't had pediatric deaths from influenza, but we will again hope for that we don't see that this year if we are able to protect everyone through vaccination. The next slide, I wanted to just bring up a question that I get all the time, which is trying to predict again what is going to happen this season. And we do have some clues from what has happened in the Southern Hemisphere, where there is surveillance for influenza cases through the Global Influenza Surveillance and Response System, which is through the WHO, and this is one of their graphs. And again, we don't know if this will be the same in the Northern Hemisphere, but as they finish their winter, in countries in the Southern Hemisphere, they have noted that even though there's continued testing for influenza in many of these countries in the context of COVID, there is still a relatively low level of activity of influenza compared to previous seasons. If you see in this graph, there has been, however, influenza B and influenza A, which is the blue colors, detected throughout the world. And the next slide, the last slide regarding the epidemics, you see again that it's not an issue of us people not looking for influenza, but it's rather that it's very low. And this is a global picture as well of the global influenza surveillance system, where you see in the pink and the testing in the bars and then the positives for COVID-19. While in the blue, you see the testing in the bars for flu, which has occurred even maybe at higher levels than what we did before in the previous season. Yet the positives for influenza remain relatively low. So we will see what happens. Next slide, please. So in general, we expect then that both influenza viruses and SARS-CoV-2 could be circulating this fall and winter, and that of course it's possible to have both infections at the same time. And it's very difficult as clinicians to differentiate both diseases, especially early on in the course of the illness. So we would need potentially to be testing and continuing to test as one of the recommendations this season to know which one we're dealing with. Next slide, please. This is just a table to try to, again, point out some of the main differences, if we can, between influenza and COVID. They have similar ways of transmission. We know that influenza is much shorter in terms of its incubation period. It's 1 to 4 days, but COVID-19 could be as short as 5 days as well. Both very contagious, especially if we talk about the current Delta variant, and both present very similarly with a upper respiratory illness, but also systemic symptoms. And the complications, as you can see, are quite similar. I mean, clearly, if you have something like MIS-C or a loss of taste or smell, that would be more characteristic of COVID. You would be thinking of that. But I think that the main message I would like to bring is that clinically, it might be really very difficult to differentiate the two. The next slide is showing you the impact. And as we know, in a regular influenza season, up to 10, 30, even 40% of people can be infected, and the children do have the highest attack rates and play a very important role in transmitting influenza. And if there is influenza circulation, it's possible that they will have the same role and we will see the same concern. They do have increased risk for complications, especially young children under 5, and they do have a higher likelihood of going to the doctor because of the symptoms that they have. The next slide. As a reminder, the complications for COVID-19 and influenza can be very similar in terms of the risk factors, the groups that could have complications. You can see that it's the same groups, persons who have immune deficiencies or any problem with their immune system due to medications and unable to respond to the virus, heart and lung diseases, chronic kidney disease, obesity, as a matter of fact, had been identified as a risk factor for influenza even before COVID-19 came along. And you see other children under 1 and those children of any age with some metabolic disorders could also be affected. Next slide, please. And again, without trying to repeat, this is still data that is looking at the cases of laboratory confirmed influenza hospitalizations. You do tend to have a pattern here with similar to what we're seeing now actually with COVID, that even children with no underlying conditions could come in with severe complications and be admitted to the hospital. But those with lung disease and now neurological diseases would be at higher risk. Next slide, please. So these are the groups that we consider high priority for vaccination. And Dr. Shea already went through this. It's basically the same list that you see from CDC is what the American Academy of Pediatrics supports. And so these populations, as mentioned before, would need to be definitely a group that is in our minds to offer influenza vaccine as soon as possible this season. Next slide. Regarding testing, just to complete that concept, again, it's very difficult to assess with symptoms, and fortunately, we do have PCR testing that is more widely available right now. And a lot of the tests include both influenza and also SARS-CoV-2, but as well in many cases RSV, which we have seen this summer, and other respiratory viruses. So in addition to being aware of your local epidemiology to see what is circulating in your community, it will be important to continue to offer the testing by PCR when you want to try to make a specific diagnosis. Next slide, please. And here are just the recommendations now, specifically for this year from the American Academy of Pediatrics. The recommendations have not changed compared to previous years in that the AAP recommends annual influenza vaccination for all children 6 months of age and older, as well as adults. And of course, any licensed vaccine that is appropriate for the age and health status of the child can be used. We don't have in the AAP any preference for a particular influenza vaccine or one product over another, as long as there is no contraindication for the use of a particular licensed age-appropriate vaccine. Next slide. The updates for this year, it has been mentioned already, there's new updates in the composition of the vaccine with new influenza A strains. But all the vaccines that are available this year for children, as they have been in the year before, are quadrivalent. We do have new formulations available for children, as was mentioned before, and there's no change in the AAP's recommendations regarding egg allergy guidance. We do emphasize the importance of influenza vaccination during the pandemic, and we also agree and concur with the guidance from CDC that co-administration of COVID vaccines and influenza vaccines is allowed. We don't have, as we have heard, any concerns regarding vaccine supply, and my understanding is that there's quite a bit of vaccine already that has been distributed. Next slide, please. So this is, if you could move through some of these rather quickly, because I think this is already, if you could click next, please. These are animated slides, so I'm hoping that they will come up. Can you press next, as in next slide? There we go, and next again. Just go through some of these. There you go. So Dr. Shea already mentioned, and this is just to make the point that the influenza A strains are new this year, while the B strains are unchanged. Next slide, please. And again, if you could also click through these again and again. This is the summary of what we mentioned before. This is some of the abbreviations that we use, standard IIV for inactivated, LAIV for live vaccine, and then there is cell culture-based vaccine that is inactivated as well. But remember that all pediatric influenza vaccines are free of adjuvants. Most are single dose, preservative-free and pre-filled, so meaning pre-filled syringes, meaning they don't have thimerosal or any concerns for preservatives. And that intramuscular injection is available for, vaccine is available for everybody 6 months of age and older, while the cellular vaccine is for 2 years and up, and the intranasal vaccine for 2 years and up. Next slide, please. So this is just a table to show you all of the different products that could be available. As we mentioned before, practically all of the vaccines, as you can see, can be given starting at 6 months, with the exception of the cell-based and the live vaccine. But the cell-based, you've heard the changes. We had initially a recommendation for 4 years and up, but now we can start as young as 2 years and up to start using this vaccine. Next slide, please. And here is the same algorithm that we have used in the past, to try to remind everyone that for children 6 months to 8 years of age that have not been vaccinated in the past or have incomplete vaccination, so had not received 2 or more total doses of vaccine prior to July 1st of 2021, they should have 2 doses given with a 4-week interval between the 2. While children 9 years of age and older only need 1 dose regardless of previous vaccination history. And our goal is to complete immunization by end of October, as we usually do. Next slide, please. If you could also click through these, there are several bullets, and that is the last one. Thank you. To reemphasize the point that influenza vaccination is particularly important during the COVID-19 pandemic, because of the how unpredictable flu can be and of the concern that co-infection and co-severity of infection could occur. So we have supported the recommendation and guidance that these vaccines can be given at the same time or any time before or after each other if that is appropriate for a particular patient. I think in pediatrics, as we are heading towards potentially having vaccines for children 5 to 11-year-olds, and we already are giving the COVID vaccines to 12 to 15-year-olds, it will be important to have a conversation with the parent to know what the expected reactogenicity profile is and make sure that there is agreement that parents want to have both vaccines at the same time. However, they don't have to be given at the same time. If they prefer to give them separately to try to reduce any side effects, then that is totally appropriate as well. Now, children who are ill, either with COVID-19 or any other illness, similarly, if they have moderate or severe illness, they should be waiting until they recover before they get vaccinated for flu. And then children with mild illness could be vaccinated. So keep up with those guidance as they become available, because we are expecting changes with COVID-19 vaccines. Next slide, please. And then here, just a reminder that as we have before, we don't have any changes in the recommendations for egg allergy. Egg allergy does not increase the risk of anaphylactic reactions to flu vaccines, and there are no special precautions when giving flu vaccine to children who have had a history of egg allergy. We do ask about general reactions to previous vaccination in general, but not specifically to eggs. And children who do have any reaction to allergic reaction to a flu vaccine could see an allergist to see if they could receive vaccines in the future. Next slide, please. The contraindications for the inactivated vaccines, those given as an intramuscular injection, are really based on the age indication. So we don't have these vaccines for children under 6 months of age. We talked about those with moderate severe illness is more of a precaution and wait until they recover. But really the contraindications here are listed based on anaphylactic reactions to previous vaccination and precaution for Guillain-Barré syndrome due to previous vaccination. Other than that, no specific contraindications, and the common side effects are related to injection site reactions, even in children who might have a day or two of mild systemic symptoms. And the next slide gives you the LAIV contraindications and precautions. If you can go to the next slide, it is a little bit busier just because, again, it has specific age indications. So we should not give it either to anybody who's had an allergic anaphylactic reaction to the vaccine, not to children younger than 2 or persons more than 49 years old. And this is one of the contraindications is children 2 to 4-year-olds with asthma or wheezing. But for those, as you can see there, with underlying medical conditions and asthma in more than 5 years of age, similar to those with moderate to severe illness, it could be a precaution for those groups. Okay, Guillain-Barré is also listed in the same way, and in this case, the potential side effects are related to the rhinorrhea and local reaction from the immunization. Next slide, please. And I think that, I guess, just to now finalize the comments, AAP also wants to make a statement regarding healthcare provider vaccination, and that the AAP supports the mandatory vaccination with influenza as well, including in outpatient settings. And this is important now, also now that we talk about COVID vaccination. So next slide, please. And for the treatment of influenza, these recommendations are exactly the same as described by Dr. Schaefer, CDC. They have not changed over the last year, and we continue to prioritize and offer treatment for those with high risk for complications, or those who are hospitalized and progressing, and considering treatment for those that can be treated early on in the onset of symptoms, especially that have high risk contacts at home. Next slide. The doses and the treatments that are available are listed here. Dr. Shea already went through these, so I won't repeat. Next slide, please. And this is considerations for administration during the pandemic. I think that we have learned quite a bit about this in the last year. I think that people are now a lot more used to telehealth and also to drive-thrus. Nevertheless, it's important to make an emphasis of the fact that vaccination in the medical home at the physician's offices is ideal and recommended, and that this is an opportunity not just for immunization with influenza, but other immunizations, COVID-19 vaccination, routine care, and additional guidance for preventive care for the family. So we do follow the CDC guidance regarding how to give these vaccines, as you can see there. And the next slide is just to emphasize again the planning. I actually think that maybe I'm hoping that the interest from patients in flu vaccine might be higher this season, because again, we have all of the elements in place to be concerned that there could be a more severe season, although we don't know that, and we might have more evidence of this as we go along. But it's important again to have everyone involved in your practices and in any contact with patients to emphasize the importance of influenza vaccination, the fact that we can do this safely in the offices, and that we have still concerns regarding the co-circulation of SARS-CoV-2 with influenza. So we have adapted very well, I think, with all these innovative vaccination strategies, and I think we should continue to utilize them during next season. Thank you so much. And the next slide, I think we are here now with a quick summary. Again, without having to repeat, this is mostly for you to keep in mind all of the main messages we have given: co-circulation, similar clinical presentation, the importance of testing, and the fact that influenza vaccination is really our main tool to prevent this disease this year. But we also have treatments available to reduce the impact of this infection and also help with the pandemic. I think I have one more slide that is a summary at the end, please. One more. If you go to the next slide. This is, again, we all know this, immunization is the most effective public health strategy to prevent influenza, and it's particularly important this season during the COVID pandemic, and that the recommendations, as we have stated, are the same: 6 months of age and older, 2 doses for underage as needed, any vaccine can be used, and that we can co-administer these vaccines with influenza and COVID vaccine. Next slide. These are some of the AAP resources, just like where some of the CDC resources were shared. Next slide. And also toolkits that are available to you for educational purposes. Next slide. Thank you so much for your attention. I will pass it back on to our moderator.
Thank you so much, Dr. Munoz. Presenters, thank you for providing our audience with this timely information. We will now go into our Q&A session. Please remember that to ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question. For our presenters, the first question asks, can baloxavir be given shortly before or after a COVID vaccine administration? I'm happy to repeat the question if you would like. Thank you. I think we may have 2 lines unmuted. So if everyone can please mute themselves. Thank you. So just to repeat, the question is, can baloxavir be given shortly before or after COVID-19 vaccines?
So I can start with that. We actually have guidance regarding antivirals and when they can be given in relation to vaccination. In the case of inactivated vaccines, there should be no concern with using antivirals. As a matter of fact, when you have a situation where you have high risk in a patient of becoming infected with flu, as in there's already a high level of influenza circulation in the community and the patient is of high risk, knowing that it takes about 2 weeks to get immunity from the vaccination, one option that is available in terms of use of antivirals is to use it as a prophylaxis for that 2-week period of time until they do develop their own immunity. And antivirals will not interfere with the immunity produced by inactivated vaccines. On the other hand, for the live intranasal influenza vaccine, which does depend on the replication, controlled replication of the virus in the nasal mucosa, it is not indicated. There should be avoidance of antivirals after intranasal vaccination. And the time is variable depending on the duration of the effect of the antivirals. So indeed, if you start an antiviral after a live vaccine administration, it actually basically counteracts the effect of the vaccine. And the duration of time as to when you can use an antiviral after vaccination, or when can you vaccinate after using an antiviral, is available in the policy and the recommendations.
Thank you very much for that very helpful answer. And for our audience who may be looking for those documents that Dr. Munoz was referring to, please note that the contents of this presentation, as well as additional resources, are available on our COCA call webpage, and I'll share that link towards the end. Our next question, and this is actually quite a frequent question we're seeing, is can you speak a little bit more about co-administration of the COVID-19 vaccine and the influenza vaccine, which currently could be happening for ages 12 and up, and may soon be happening for younger children as well. So can you please address co-administration of those two vaccines in these pediatric age groups?
Sure, I can start with that. This is David Shea. Yeah, there, as we both noted, there are no contraindications. It's actually encouraged if it's useful, if you've got someone who's in the office to get a COVID-19 vaccine, if there is an age-appropriate flu vaccine available, to offer it. And as you noted, at this time of year, it's a perfect time to get an influenza vaccination. So there are no known contraindications to administering those vaccines together. I don't know if Dr. Munoz would like to add more.
Thank you, Dr. Shea. Yes, I think this is a very common question because parents are trying to make that decision, and providers as well. I think that one important message is that we do not want to miss opportunities for vaccinating children with these two vaccines. And so the co-administration allows for a one-time visit and not having concerns with missing a chance to get vaccinated in time. These recommendations are also based on what we know regarding co-administration of inactivated vaccines, as these two are, especially when we're talking about IIV and current mRNA COVID vaccines that we can give to children, that there should be no reason to be worried about interference with the immune response. Our immune system is very much able to tolerate and respond to multiple vaccines at the same time, and that are given in the same manner. And then again, in terms of safety, we are very well familiar now with the safety profile of these vaccines. And if we know what to expect with each one of them and inform the families that these potential side effects could occur, then everyone is prepared. And you could also consider recommending or telling parents that obviously they can treat the fevers, they can treat any of the side effects after vaccination if necessary as well. So I think at this point, it's very clear that the co-administration or any administration without any concern to intervals between the doses is appropriate.
Thank you to you both. The next question we have is, we have also seen various versions of this today pop up in the Q&A box. And the question really amounts to, should antiviral treatment be started only after a positive test for influenza, or should antiviral treatment be started while waiting for results? And I think the reason is, I think probably because of a lot of similarity between symptoms between influenza and COVID-19.
Right, I could probably start with that. This is Flor Munoz. So you're right, traditionally, every season we have stated that you don't have to wait for the results to come back, because we have a pretty good sense of when influenza is circulating in the community, and that if you have an illness that looks like influenza in the middle of influenza season, that it's likely influenza, and so we should offer treatment without having to wait for a result. It does pose a little bit more of an issue right now, given the persistent circulation of COVID-19, of SARS-CoV-2, and the similarity of the illnesses. I think that in order to make a decision, it's going to be a little harder at the beginning when we don't have a lot of influenza out there yet. And testing is what will allow us to determine whether flu is out and have a sense of how active the outbreak is of influenza. So I think early in the season, right now, if I were to be seeing a patient with fever and body aches and different symptoms, I would probably think of COVID first, based on the epidemiology. But I would like to, I would test and wait for the result, because that would help me determine the treatment. I think that if I started to see more influenza in the community, and clearly we're in the middle of the influenza outbreak and I have a patient with that, I would probably start treatment for influenza right away before waiting for the test results, because I can treat that and help them recover and do better, even if they have COVID infection as well, or hopefully less likely COVID at that moment. So we have to be clinicians, I think, in this case, but also be aware of the local epidemiology and circulation of the virus.
Yeah, I would totally agree. This is David Shea. Know your local and regional influenza activity and make treatment decisions accordingly.
Thank you for that. Our next question is also about the antiviral baloxavir. And the question asks, do you consider baloxavir to be a viable alternative if zanamivir is contraindicated for whatever reason?
I'm not sure if Dr. Shea would like to comment, or.
Go ahead, Dr. Munoz.
Okay, thank you. So yes, so the difference is certainly baloxavir has its own specific age indications. So as long as you are in the proper age indication, and especially for ambulatory patients, I think baloxavir is a good option. It's a single dose or oral administration. It's very effective, especially against the flu B strains. It seems from what we're seeing in the Southern Hemisphere that influenza B strains are going to be circulating. And so that could be helpful. And it could be, potentially better tolerated than a 5-day course that you would do, say, with oseltamivir, which is the oral counterpart. So the question specifically, baloxavir versus zanamivir, yes, as long as you're in the age group that for which it's recommended, it should be okay.
And I would add only that it might be a particularly attractive in a setting where follow-up might not be assured or more difficult, for example, in an emergency department or an urgent care setting.
Thank you very much. We have time for one more question. And the question asks, do you anticipate any changes to CDC ACIP's guidance or AAP's guidance for younger children this flu season as COVID vaccines receive additional pediatric authorizations over the next several months?
In terms of, this is David Shea, in terms of influenza recommendations, or, I mean, I think we all know that the COVID-19 vaccine EUAs and eventual licensures for younger children are coming. I mean, I don't anticipate that there would be any changes, certainly in the ACIP recommendations for the use of either influenza vaccines or influenza antivirals in the next few months.
I think I would agree. I think that the guidance that is available right now has taken into consideration the co-administration questions, the safety profile, and the timing of the vaccination. I think, if anything, I would say we would be in agreement that supporting vaccination of children with these two vaccines is very important this season. but no particular changes in what we have already provided as guidance.
Great, thank you so much. I want to thank everyone for joining us today, with a special thank you to our presenters, Dr. Shea and Dr. Munoz, for sharing their expertise. Next slide, please. All continuing education for COCA calls are issued online through the CDC Training and Continuing Education online system at https://tceols.cdc.gov. Those who participate in today's COCA call and wish to receive continuing education, please complete the online evaluation by November 8, 2021 with the course code WC292-100721. The access code is COCA 100721. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation between November 9, 2021 and November 9, 2023, and use course code WD2922-100721. Again, that access code is COCA 100721. Continuing education certificates can be printed immediately upon completion of your online evaluation. A cumulative transcript of all CDC continuing education obtained through the CDC Training and Continuing Education online system will be maintained for each user. Today's COCA call will be available to view on demand a few hours after the live call. You can find the video recording and the additional materials that were discussed, such as resources and slides of today's COCA call at emergency.cdc.gov/COCA. Again, that's emergency.cdc.gov/COCA. Continue to visit emergency.cdc.gov/COCA to get more details about upcoming COCA calls, as we intend to host more COCA calls to keep you informed of the latest guidance and updates on COVID-19. Please share these call announcements with your clinical colleagues. You may also sign up to receive weekly COVID-19 science updates by visiting this link on this slide. Next slide, please. COCA call announcements for upcoming COCA calls and other COCA products are sent via email. In addition to visiting our webpage, please remember to subscribe to COCA to receive notifications about upcoming COCA calls or other COCA products and services. Be sure to subscribe to receive notifications by going to emergency.cdc.gov/COCA. Next slide. We invite you to join the COCA email list by visiting the COCA webpage at emergency.cdc.gov/COCA. Click on Get Email Updates and enter your email address where indicated. Finally, to stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Next slide. Thank you for joining us today for today's COCA call, and have a great day.